A very good afternoon to all of you. Myself, Austin McEwen, welcome you to QRMD's webinar, Must Know the Secrets of Easier EHR Documentation. In this webinar today, we are going to throw some light on how to document in the best possible way and in less time. Before we start the presentation, I would like all of you to know that we will be tweeting live on hashtag QRMD webinar, as you can see at the bottom of your screens as well. So please feel free to drop a comment or a question. We will definitely try to entertain as many questions as possible by the end of this presentation. If, however, your questions are not answered, we will respond directly to you in the coming few days. And we would also be conducting a brief poll during the presentation. Please do participate, as it will help us in guiding you better. Now, starting with the presentation, I have with me today Joe Martin. Joe is the Key Technical Services Account Manager for QRMD Healthcare and one of the lead trainers for the organization. With over 10 years of experience in healthcare and customer services, Joe is a walking almanac with answers to frequently asked questions ranging from ICD-10 to meaningful use. His knowledge and experience make him an invaluable member of healthcare IT community. So over to you, Joe.
Thank you very much, Austin, and thank you very much, everyone, for joining us on today's webinar. So let's start. So let's talk about the perspective from an unhappy EHR user. So let me introduce you to one, and let's see what things they will come across on a daily basis and what will they say if they're not happy with their EHR. So first of all, my EHR has slowed me down. I'm seeing less and less patients every day. My practice is taking a revenue hit since I'm an electronic and there is no recovery in sight. And last but not least, ICD-10 is coming. And if my EHR is the only savior I have, I should kiss my practice goodbye. Right, so if an unhappy EHR user is thinking that there is a problem with their existing system, they can be one or two things. Either they have the wrong system. Secondly, they are doing something wrong. So let's have a quick comparison and see if they have a wrong system, what problem would they be facing. So if they're using the wrong system, they must be using a generic system. For example, there's a few systems right now in the market which are just marketing as a free EHR. They do not provide one-on-one training. They don't have a standard notes. If any of the staff needs to be trained, they'll just be given with 100 pages of documentation, and everyone has to work on them themselves, which is really difficult for a practice. Because, it's implementation and training is really important aspect of implementing any system, especially in the EHR market. The other option that some of you might have come across is some of the companies have been running a successful billing, systems, and they have been using billing and doing billing for many practices for a long time. And sooner, when the EHR from the last few years, when the EHR was really dominant in the market, they thought that, okay, you know what, let's start an EHR so for all our billing clients, and with this way we'll increase our revenue as well as the clientele. So the main focus that they had was not actually enabling the system for their existing clients, but just for the sake of requirement that it's something that they can make money out of. So the main focus that they had was completely off target. The next few things, if you think that you do not have enough reporting privileges or you do not have enough reporting criteria available in your system, so that means you have a wrong system. The other thing is if the system is built for a non-familiar platform. Let me explain. So let's say if you're a Mac user or you're using an iPad and then you have to switch to a system which is a desktop or a Windows-based system, then of course it means that you're shifting from your comfort zone to another platform. At the same time, and this is the most important aspect in my understanding, and I personally think this is the most important one, the support is negligible. You need to call somebody and you need to ask them a question. What they need to do is they'll give you a manual. You have to look through an answer over there. You have to create a ticket and wait for 2 days before somebody replies to you by email and giving you a completely different answer which you're not expecting. So this is most important. You need to have somebody that you can talk to. You can fix an issue by talking to someone within 2 minutes rather than waiting for somebody to email back to you in 48 hours and then still the issue remains the same. Now let's talk about if you think you have what are the examples of the right systems. The right systems are specialty based. They give you proper training and take a lot of time and a whole hand as well with the practice and the administrators to implement the whole system. They put their heart out and make sure that you guys are comfortable with the system before they take you live. They customize everything for you, including provider notes, which is the most important factor for billing or anything that you can see. The doctor has to be trained. The doctor has to be familiar with the provider notes. He has to be comfortable in using the flows of the provider notes. Same goes for the patient care. It has to be built in, and the practice productivity insights too, as well as we were talking about the platform. If you're, let's say, I'll give you an example of CareMD over here. Right, we were originally on Internet Explorer and we were on a desktop based, and then of course our clientele did mention that, hey, you know what, we're using Mac or we're using iPad, we need something to be used over there. So then we came across and we just made our Avalon app in which you can use it on your iPad or on the Mac too. And lastly, support is available when needed. You need to talk to somebody. Somebody should be there on the other line. You don't have to wait for 2 days before anything happens. Right, so we're going to move on to our first question in our polling questions. So I would like you to just take a moment and tell us that what category do you think you fall in? With the system that you're currently using, you think you have the right system or the wrong system? So you should have the poll question coming up on your screen. So I'll just give you a few moments actually to do that. Okay, so we'll be sharing the results with you right now. So around 60% of you think that it's you have the right system. Around 40% think that they have the wrong system. So now if you, let's say for those 40% of you who think you don't have the right system, then I think the best thing for you to do is to explore the market. Okay, you have a lot of systems coming up over there, including ourselves, and we are really proud to say that we provide all the essentials that are required to have a right system for you. Right, so now let's move on to the people who think that they have the right system. Now my question is this: if you're still spending more than 10 to 15 minutes on a basic, simple patient visit, then it means if the answer to that is yes, then of course you need the EHR documentation fix. Okay, so the question is actually why bother with the documentation? So now, in a nutshell, of course, we have to understand, everyone knows about this, documentation is really important. Regardless of whether it's current care or subsequent care, or you have to think of it in the legal point of view that you have to document every single visit to be for use later on. And now before, some of the doctors, what they used to do is like they were not familiar with this with the electronic systems. They used to just put it still on a paper if they're retiring soon or anything, or any other way as well that it's too complicated for them. They used to just create paper notes or anything. But now that has to stop. When ICD-10 kicks in, every single note has to be documented. Every single visit has to be documented in detail, following the EHR standards, keeping in mind the meaningful use requirements that you have as well. So every single thing that has been asked for you previously, you have to make sure that you have everything documented in a structured or reportable manner, so otherwise you won't get paid once the ICD-10 kicks in. Now, what are the problems that you would come across? So let's do a quick comparison of having a pre-EHR and post-EHR era. Right. So when there was no EHR, everything was on paper. The question was, if it's not documented, it didn't happen. So which means that, let's say if the documentation was not done, then of course there was no record. It means that the visit did not happen. And let me just share with you a few, one of the figures that we have is about the care settings and a certain amount of time that was spent having the time spent on documenting data. So, for example, the emergency and department care, if there was a 1 hour spent with patient care, there will be exactly 1 hour again has to be spent to document that visit. For surgery, 36 minutes. For skilled nursing care and outpatient, it will be 30 minutes too, and home health care is 40 minutes. So now, let's move on to the post EHR era. Now, what's the question now? If it's documented, was it done? In other words, was it done properly? So let's talk about why is it important to have a properly documented visit for every patient. Now, the results of the recent CMS study suggest that OIG, which is the Office of Inspector General, will find plenty of E&M documentation problems amongst EHR users. And outcome of those improper documentation can cost the physician from $50,000 to up to $150,000 in paybacks. So, which is something that you have to be really careful about, and that's something that you need to make sure that you have the proper documentation. Now, this example itself should be enough for us to make sure that we document everything properly. So, coming back to the whole question, we were talking about 7 secrets, Now, let's talk about these things. So, we switch our secrets to commandments now. So let me tell you, what can you do in order for you to make sure that you're documenting everything properly? So talk about number 1, the dead doc rule. Actually, that came across. It might be funny as well, but then it's really important. If something happens to you, can someone else know what you did by looking at your notes? Or let's change it. Let's flip it around. A physician, like a patient physician, he's no more, okay, or just gone, or the patient has moved somewhere, and he's taking all the notes from a previous provider. If you look at them, would you like to see a properly documented notes, or would you be or is it something that you're going to have a really trouble, understanding that how this provider recorded those notes? So the same thing applies to you. You need to make sure that documentation that you do has to be in such a way that it's easier for other physicians to understand. Number 2, do not compromise on documentation integrity. Now, from every exam component or anything that you have, you need to make sure that if you performed a task, you record it. If you did not, do not mention it. Now, this is another important thing. You are putting yourself and the institution at great risk if you're entering something which you did not perform at the time of the visit. Now, there's a really interesting thing, actually, that I'm going to share with you. We had a case study that I came across, and, in a nutshell, actually, you guys will have this slide so you can study this in detail. So, one of the nurses actually was waiting for one of the patients to be seen. The patient came up with a minor precaution, would then complain about the neck and I think leg pain as well. So the physician came in, entered the door with a tablet in the hand, just talked to the patient for less than a minute, and walked out. Now, the nurse actually, just out of curiosity, she said, "Okay, you know what? I need to see what did the doctor do." And when she pulled out the note, it was such a beautifully organized, complete visit detail, and she was surprised that within a minute the doctor has just created this 3 or 4 pages note. And when she further looked into it, most of the things that was mentioned over there, the doctor did not even ask. So it's not the amount of information that you put in the note, it's how accurate that note is. So that's something that you have to make sure that you comply with too. And secondly, the amount of time that you spend with the doctor can be seen. Let's say, talk about the private practices. So you have a check-in and check-out time. You will be able to know how long the patient spent over here with the doctor. And that's something that the CMS or OIG will look into before it's coming up. If they spend about 10 minutes with you and you have a note that goes for 5 pages, of course, they will find out that there's something not right over here. Right, so moving on. Number 3, which EHR and entry modality to use. Now, let me explain, actually. Now, there are different ways for you to record a certain note or certain visit. Now, there is no one way that you can say, okay, you know what, I'll use number 1 or number 2 or number 3, number 4. So you have to use a hybrid sort of model that you have. So let me just go through different methods, and of course, based on that, you can just decide which one that you lie under and which is something that you are comfortable with. Okay, so looking at the first method, which is the structured templates. Now, I'm not going to go into detail, but let me just tell you the gist of it. So, advantages and disadvantages of this particular, let's say, method. So, for the structured one, the way that it's supposed to be is you'll have a pre-filled sort of template that you'll see in your EMR, or you'll have something that say vitals, and then of course they'll have a blank space next to it. So that sort of templates that you have is called the structured templates, where the information is listed out and you have to fill out the information over there. Now this sounds better, and it's a really good thing for you to have, because it's most of the information is already pre-filled, and it just makes it easier for you to do that. But there are some disadvantages. The first and foremost is, let's say you mark a particular exam as all negative or all positive. Now there are 15 different aspects of that exam, and you just simply check the box as all negative or something. Now this is going to be really important. This is something that you have to explain yourself afterwards, whether did you do all of these steps over there, or just did you mark it all negative. And sometimes it happens that physicians tend to forget about a certain procedure code that they have done or not, or they have performed a certain task. So that is something that marking, the ability to mark all positive and all negative would come across a bit of an issue for you later on. The other thing that I personally think would be an issue over here is the way that a note is organized. So the way the information is put in over there, it can be easier for one person, but let's say it would not be good for another person as well. So let's say another physician would like to see information in a certain order, and on your side you have the empty spaces and all the filled out information. So that is something that some people might not like. Right, so moving on to the next method that we have, which is the radio buttons and drop downs. Now this is something that everyone likes. Most of the physicians would, or any of the MAs, or let's say the NPs, would love to just have the point and click, and then just complete the whole note. Now it is in a way it's easier for everyone to create it and then everyone to use this feature, but there are certain disadvantages to that too. Now, if the EHR has the ability to convert those radio buttons and the drop downs into a set text, then of course it's the best thing to have. Then of course, I'm going to destroy the example of QRMD as well. For a HPI, when you're recording over here, you have the set of drop downs and check boxes over there. Just put it, check those, and then you have the ability to, have a complete text coming up over there. The patient presented with this, and and so on and so forth. So that just makes it easier for everyone to do. But at the same time, if you look at it, and this is one of the things that we came across really often, and we had to analyze the data as well, people tend to make more mistakes. When you have checkboxes and different items drop downs, you tend to select the wrong information over here, and that is something that really come across where if the note is signed or something, or if the note has been finalized, then you realize you were going in the flow and then you just check the wrong information over there. Right, so that's one of the disadvantages that I thought that it would be a bit of an issue. And but as I said, this is one of the most common one. One of the most favorite, I would say, would be this option that you have the ability to point and click. Right, so the next option, which is not so popular, but then still you'll be surprised everyone is still using it, manual data entry. People would have their staff type in the whole notes, whereas it's honestly it's with now, especially with Meaningful Use Stage 2 and the industry going to a certain standard, that's going to be obsolete. Okay, the information that you have is not reportable. It's not following the EHR standard or EHR industry criteria. This is not going to be, if you're using the same thing, if you're getting the notes and copying pasting it on the other side, that's not going to help you in future, and that's going to have a bit of a consequence once the ICD-10 kicks in. Right. So, no, but at the same time, if you think about it, it is okay for some of the surgical practices when they have to note down a certain information, but still, that information has to be in that surgical note, as well as the clinical component still has to be used. Moving on to the last option, which is our transcription service, let's say. So the voice dictation, and let's say you have the voice dictation or any transcription service that you use. Now that is something that is I have to admit is getting really popular these days. Because now, if you think about it, 4 years ago, 5 years ago, the doctors were still using the paper charts. They were not using this in detail. But things, I have to say this, things did not get easier for them. Now, rather than just documenting a certain information, now they have more and more information that they have to document every single day. And with the ICD-10, it's not going to be easy. You're going to have more information that you have to document with every single visit, and more detailed information that you have to put in the provider note. So, how can we make it easier for you? How can which method that you think would come across and help you in future? Now things are not getting simpler. It's more complicated, more detailed visit that you have to record, more time you have to spend in entering all the information in your EMR. So, how does it help you? You need to use a service which is we call it discrete reportable transcription. So reportable is the important aspect over here. If you need to use a dictation service and it simply converts it into text, that's not going to be helpful to you. So you need to make sure that whoever staff that is using or just after listening to dictation, they are just creating the notes. They need to make sure that they are entering all the information in the clinical components. Otherwise, your visit will not get paid, especially when ICD-10 kicks in. So now I would like to mention that we do have we mentioned in our last few weeks ago, we launched it in our webinar too. You have the discrete reportable transcription service that QRMD offers. In there, you will be able to use the same options, and you'll be able to, all the information will be entered in the clinical components. Right, so in my personal opinion, with now, you'll have to spend a lot of time in recording everything for a patient visit. I think that's the right time for you to move to the transcription service or any other method that you have. But keep in mind, you do not use something which is simply copy-pasting the note onto, from Word document to the provider note. It has to be reportable. It has to comply with industry standard. It has to comply with meaningful use, otherwise it will be useless for you to use it. Right, so we're moving on to our next following question, which is which entry modality do you prefer in your EMR? Right, so you should have the questions coming up. I'll give you a few seconds actually for you to answer the questions. We're still receiving the responses and all, so just bear with us. All right, thank you very much everyone for your responses. So as you can probably see, over 55% of you said a little bit of everything. So that is absolutely the correct thing to do. So the best practice that you have is the blended approach, which is a little bit of everything, so which you guys are correct. Of course, you'll have to change this, based on your requirement and your practice workflow. So what are the benefits of this blended approach, which you said like a little bit of everything? So it does not disrupt your physician's workflow. It facilitates better physician adaptation and achieve faster, meaningful use of the EHR. Okay, so now this is something that we have to make sure that you guys are you understand this, and this is something that you have to make sure that you implement this in your practice too. Every staff member that you have would be able to help you in making sure that the blended approach is used. Okay, you need to make sure that you define your workflows in your practice. So if there is any information that that nurse practitioner or let's say MA can take, we'll have to make sure that they put that information in. So more you have these workflows defined in your practice, it's going to help you. And now, as I said before, things are not going to get easier. You have to record more information. So utilize everything in your everyone in your practice, assign them certain tasks, and let them help you in documenting a good provider note or good documentation for a patient visit. So let's look at the rule number 4. So what are the things that you should not do? Okay, so there's quite a lot of them as well. I'll just share a few with you. We have to make sure that we don't get lost in the point-and-click mentality. Okay, you have to make sure that everything that you have done is entered properly, and it is the thing that was performed in there. Copy and paste forward is one of the most common things that we come across. Simply move the note from the last visit to this one. That is not recommended. It can be used, but then you have to. We'll cover that later in the next, our rule number 5 as well. But then this is something that you have to be careful about. Okay, charging for the service that were not performed using a default entries, make sure you don't have those entries there. You need to make sure that if it's a set, information is coming up over there, make sure to remove the information which is not performed on that particular visit. Now, negative listed versus positives. Now, it's this is another thing that I mentioned earlier. Actually, you have the option in the review of system or physical exam to mark all as negative. In ROS I was talking about all negatives or all positive or all normal in the physical exam. Just make sure that we don't overdo it, and we make sure that if there's anything, we're not misusing it or something that we're not, ignoring it afterwards. So that is something that you have to be really careful about. Inaccurate charting, of course, that as we mentioned before, addendums for increased reimbursements versus patient care. Now, this is another thing that we mentioned in our last webinar, because what's happening now, it's the trend actually in the market, it's the increased reimbursement is based on the quality of care. So that is where it will be dependent on. We'll have to make sure that we concentrate more on that rather than overcharging anybody. Of course, the relative value units, or we're talking about the signing of notes without reading them. Let's say if any of your interns is creating a note, you just make sure just to glance through it, just review it before you sign or sign off on any notes. If anybody else is signing it, you will have the option in your EHR to sign off that note. Make sure you're doing that. Right, and EHR revealing bad practice patterns, that's something that you have to make sure. If there's anything that you think it's just taking towards the wrong trend in your practice, make sure you avoid that and make sure you fix it straight away. Right, let's look at the number 5, which is top compliance rules for an EHR. So now we have the use copy forward with caution. Remember, we just mentioned a few minutes earlier, every patient's visit is unique. Okay, we have the options today in the EHRs to move a previous note, but you need to make sure that you edit it. You just remove the information which is not recurring. For example, in QRMD, there are certain information will not come up automatically when you try to import a previous note. For example, the HPI has to be unique. Now you have to make sure the vitals has to be unique. You cannot, even the patient comes in 2 hours later in the day, you have to take the vitals. You cannot use the vitals for earlier. It has to be taken again. So that is something the patient condition can change. So make sure that you are using the copy forward feature with caution. Right, now the notes that we have over here is copy forward HPI, exam, vitals, and complete assessment. That is something which I mentioned before. You need to be careful on that. And copy paste from multiple or complex diagnosis and dictate notes using this, free text option. So that is something that you need to make sure that any of the diagnosis information that you have, if it changes, you have to update it in the system. For HPI, we have, let's say, actually most of the EHRs should have the ability to document and a follow-up of a certain HPI. So, for example, like let's say I came up with cough last week. So, if the next visit comes in, you should have a follow-up response to that. So, you cannot have HPI and cough again in there. You should be able to update the follow-up of that particular cough. So, whether it got better or if it's the same or it has been resolved. So, that is something that you have to make sure that you do. Moving on, be careful with pre-populated no or negative templates. Same thing exactly what we mentioned earlier too. Make sure you do not have all negatives and all positives in review of system or exams. And you need to make sure that you read your assessment and plan and ask yourself, is the information contained in the history and examination relevant to the nature of the presenting problem? If anything changes, make sure that you update that. Make sure if you are using all negative, all positive, enter the information correctly, and then just review it quickly and make sure that you have the option to fix that problem rather than having an issue later on. Next, never copy anything from one patient's record to another. Well, that goes without saying, actually. That is really something that actually we hardly come across anything like this, but of course that's something that I'll have to mention over here. And then authenticate all documentation and orders in timely fashion. If there's any verbal order within 48 hours, that has to be done. 30 days for any signed document. Now, let me talk about the provider notes, for example. If I'm not mistaken, actually, for stage 2, once the patient comes in, within 24 hours of the visit, you have to sign the note. Otherwise, it will not be counted in your meaningful use data. So that is something that you have to be really careful. Now they are changing this. Before, I still remember in stage 1, you had 3 business days for you to finish a note. Now they changed it. Now they want it to be done within 24 hours, and the note has to be signed within 24 hours. That is something that they are moving forward towards, and that's something that's really important, and you need to make sure that you change your workflow based on that. Right. Again, never copy documentation from another provider without clearly identifying the original author. And said this is hardly ever happens actually. Especially nowadays, everyone knows about this, and but something that is a isolated incident that does happen. But if it's done by mistake or something, it can be considered as a false claim, and that's something that you really will have to avoid. The next thing is actually the family histories and social histories can only be entered by like any information that needs to be entered by a student or on a nurse's note should only be the history information or review of system. The rest of the information would have to be entered by the physician. Okay, so that is something that you need to make sure that you do that yourself. And lastly, in our commandment number 5 would be the consider the medical decision making or to be the most critical element in the code choice. Now, this is a similar thing which I mentioned earlier too. It does not matter how many pages you have recorded for a certain visit. It is not like that. You need to make sure that you have more accurate and more detailed information over that. So that can cause the documentation to increase in size, but then at the end of the day, it does not mean if you have a 5 pages note, that means that you will be able to bill for a higher code. So that is something that you have to keep in mind. Right, so commandment number 6, clinical workflows adaptation. Okay, now we need to make sure that for every practice, you need to make sure that you have the cross-trained staff that can handle intake of documentation. Again, as I mentioned before, documentation keeps on increasing. Utilize your staff. Have your staff, know about this. They need to make sure that they can if anybody can take the vitals or review of system, or any of your medical staff can help you as much as possible. Now, I have to mention QRMD as well over here in a way. If, let's say, if any of the clinical information was documented other than the physician, once the physician creates a provider note, any information that was documented will automatically come up in the provider note. So this way, we made things easier for the physicians. So any clinical information is added today, it would automatically show up in your provider note. So that's the whole idea. Utilize your staff. Make sure everyone knows of assign them a certain task. They do that, and it makes it easier for you to finish up note quickly and much more, in a swift manner. Right. So again, the documents as well. If there's any associated documents that you have associated with the patient visit, make sure that your staff handles that properly. You should have the document manager or any other feature in your existing EHR. You should be able to put that in there too. Right. So the last rule: regular audit of providers and the staff workflows. Whatever system that you have, once you have established what workflow that goes in your practice, once you implemented this, and again, you have to do it before end of September. You need to make sure that you have all these workflows implemented. Your staff should be trained. They should be helping you out with your documentation, and as much as possible, if you need any help with it, you can always contact your vendor, and then of course call them on their support. And of course, if they lie in the right side, in the right system, then of course they will have a support personnel, somebody that they can call you and take your call straight away. Ask them to help you define your workflows. If you're in implementation at the moment, your implementation specialist should be able to help you out and help you define all your workflows in the practice. They will tell you who can do this and where you can enter the information to make it easier for the doctors to document this. Okay, so now. Again, so the questions, as I said, as you can see on the screen, are your providers closing all the accounts every day? With the amount of information and amount of documentation increasing every day, you need to make sure that you close your encounters every single day. Okay, then maximize staff use on a daily basis. Okay, you need to make sure that you slowly monitor all your physicians' patient encounters, and then see how long does it take for them to, close it. Ask your staff to help them out and decrease that time. Okay. The next thing that you have is, how much do you have providers spending on the documentation, and how much after the patient has left. So we need to establish what's the amount of time that we normally take to record the document during a visit, and how much information that we use afterwards. Right, and you have to compare yourself with the other practices. If you know anybody, you need to just consult with them and ask them to help you out. And now, lastly, for QRMD customers, how can we make the documentation easier? We were talking about the multi-platform option. So we have the iPad app. So if you had to shift to a desktop, use the iPad app, and it will make your life easier, and it will just help you create the notes over there. We had a webinar, previously, and then you were able to. We showed you how you can create the provider notes. Use the DRT service, discrete reportable transcription. Let us help you. We will make sure that your note, your documentation is EHR up to the EHR standard. It is qualifies for meaningful use. Okay. Call your support team. Ask them to tweak your provider notes. Call us, and then we'll be able to help you out, actually. And then if you can talk to your, account manager, or you can talk to anybody in your support team, ask them to help you with your provider notes, and ask them what's the best way to increase and better your workflow in your application. Right, let's moving on to the last bit. Okay, so we have only one question left, and which is, which topic would you like for us to cover in our next webinar? We would really appreciate it if you could just choose one of the options. We will be doing electronic prescription of controlled substances webinar soon as well. That should be coming up, and we'll show you how to prescribe controlled substances in QRMD. But this is something that's really important. We would really like your feedback on this. All right, but thank you very much, everyone, for joining me, and I'll pass you back to Austin.
If it is documented, was it really done? a very important question for every practice. Thank you so much, Joe, for your time and for sharing such valuable information with all of us. So everyone, the floor is now open for the question and answer session. There are a lot of questions coming our way, and definitely in this short period of time, we would not be able to entertain all of them. But if you miss your question, we will definitely get back to you with detailed replies later. So let me see the questions which we have so far here. All right. First of all, we have Linda Brown, and Linda says, "What will I need to document for ICD-10?" So, Joe, can you help Linda?
Well, that is a good question, actually. Let me give you a brief overview of the ICD-10. At the moment, the ICD-9 codes are for the diagnosis codes. It's around 13,000. That will be increased to 68,000. For procedure codes, they're around 3,000. They'll be increased to 87,000. So the whole idea that they have is they are increasing, they're specifying every single diagnosis rather than having any disease or any procedure or any disease unspecified. They're making sure that they are pinpointing exactly what's wrong with the patient. So I came across this last year's one of the seminars that I attended, where let's say at the moment we're using the ICD-9 code. Let's say if somebody just broke their one of the kids actually just he broke his left arm, so he went to the doctor, and then of course he got treated for this, so on and so forth. 3 months later, he climbed the same tree and broke his right arm. Now, once you tried to when they went over there, the doctor billed again for the code, and turned out that they said, "Oh, you just billed for this code about 3 months ago. You cannot bill for it again." So that sort of thing. So now they are being more specific, and they are just increasing the amount of information that they require. But in a nutshell, actually, you have to describe the disease status. You have to be more specific to what code that you're using. There is a lot of detail that are required for a particular visit in order for you to bill it properly. So again, details. They want more details in order for you to bill for ICD-10.
All right, Joe. Now I have a next question for you. The question is from Ryan Gregg. Ryan wants to know that, can't my biller handle everything for me?
Well, actually, the answer to that is actually no. This is the thing, your biller would only be able to help you bill for these things. But at the end of the day, the doctor, you will have to come up with what code that you need to bill. You need to come up with what diagnosis that you're going to use. So that's something that you will have to do it yourself. The biller would only be able to, just submit the claim for you. And if it's a rejection, they will just eventually come back to you. So again, to delay, if you don't need to, worry about losing so much time in rejection handling and everything. So make sure that you know what you're billing, and whatever information that you need. We will be doing some webinars about ICD-10 once before its launch, so we will help you out with that.
Whoa, I see your more questions coming in, but as I mentioned, if you're not able to answer all of them right now, we will definitely get back to you and we'll give you detailed replies for that. I have a next question from Frank Smith here. Why choose a transcription service over a voice recognition or dictation tool?
Actually, that's a good question too. Now, what I come across on a daily basis is everyone says, "Hey, you know what? Dragon, can I use Dragon and I can use it in the EHR?" Well, of course you can use Dragon and you can dictate a note, but then that's not going to be up to the industry standard. So none of the voice recognition softwares are, able to dictate everything inside the clinical components. Yes, they can free text. Yes, you can just open up a component and then you can just point and click, and then you can dictate a certain, lines that you want to put in there. But none of the dictation softwares out there are are integrated in the clinical components or with the EHR. So this way, you cannot use them. And voice recognition actually kind of like lacks the accuracy as well. So the DRT service that I mentioned, we have a team actually that's sitting over here. You dictate your notes, and what it does is they will just go in there and they will just put all the information in the clinical components. So that's where it's it's really easier for you to dictate your notes, and we can put that all in the QRMD application.
All right. The next question is from Richard Williams. Richard says, "This all sounds really complicated. How can I do this at my practice?"
Yeah, absolutely. I agree with you as well. It sounds complicated, but at the end of the day, if you think about it, that is something that we cannot get away from. It's something that is coming our way. I don't mean to scare anybody with the ICD-10 and everything, but yeah, that's something that you'll have to do. Every physician would have to do it. We've been just dodging that bullet for such a long time for ICD-10. Now they just they just came up with a few more things. More they delayed it, more information they just threw it in. So now you cannot avoid it. You have to do it. But now, our job, on the other hand, and the whole idea of this one is for me to tell you how to make it easier for you. You cannot avoid it. How can you tackle it? So again, as I mentioned before, define workflows in your practice. Have your staff assign them a task, and then just tell them they need to do a certain task of a particular visit. This way, it will make your life easier. So this way, slowly, it will take time, of course, but at the same time, you have a few months heads up. So by the time October comes in, you will be able to define these workflows in your practice, have your assigned a task and certain tasks to your office staff, and then this way, it will make your life much more easier. So at the end of the day, you as a doctor would be able to document less things because most of the information would be documented by your staff. Utilize your staff as soon as possible. Have you define your workflows in your practice, especially have the front desk help you out as well.
All right. Michelle Reed says, I am interested in trying the transcription method for my documentation. As a non-QRMD user, can you tell me how much will this charge me?
Right. Okay. So for that, I can, if you can email us at drt@qrmd.com. It's discrete reportable transcription. So drt@qrmd.com. Just shoot us an email, and I'll just include all the information over there for you.
Right. Next, I have Palmer Wilson. Palmer says, I'm running a solo practice with a 3-person staff. These commandments you mentioned, won't they work out as a bit expensive for me, give the resource constraint for that?
Well, that's that's understandable actually, because more and more practices have less staff, and there's especially with the solo practitioners, actually that's something that you have to think of it. So now I'm going to go back to the DRT actually. Now the way that it's supposed to help you out is, let me put it this way: you see 10 patients a day. Okay. Now you have to spend a lot of time in documenting the notes. So what you do is when you doctors and as well as yourself as well, you'll find out that it's easier because you guys do it in a flow and you guys can do it quickly. You'll be able to dictate, maybe 10 visits notes, 10 visits information within an hour or so, or less than that. So what you do is you go for the DRT service, start seeing more patients. Then what we'll do is any cost that you spend on the DRT would be recovered for you by seeing more patients. If you see more patients, don't worry about the documentation. Have it dictated. Our team will take care of it, and that will just be more cost-effective for you. Okay?
All right, now this is going to be the last question here. I have Debbie Ellis, and Debbie says, I have been a QRMD user for over a year now. How do I purchase the Avalon, and I don't want to spend a lot of money?
Oh, right. Debbie, actually, good news. Actually, as I said before, Avalon is completely free. As I said before, this is a requirement from our most of our practices. They were Mac users or iPad users. They wanted to know about Avalon, and that's why we developed this app for them to use. So it's absolutely free. Just go online on your iPad, go to App Store, and search QRMD. So simply search QRMD and Avalon app would come up. just download it, and it's absolutely free for you. And so this way you can use your same logins as you have on your desktop for your QRMD application. Use the same logins, and you'll be able to. You're good to go. No need to call support for setting everything up. No settings whatsoever. Just use the same logins, and you're good to go.
All right, with this, the Q&A session is over now. I would like to thank you everyone for being a part of today's presentation, and we hope that we were able to help you with the secrets of easier EHR documentation. And if you would like QRMD to assist you any further, you can definitely contact us in following ways. You can either request a demo to see how QRMD can facilitate your practice for easier EHR documentation, or you can get in touch with our documentation experts at 718-684-9298. And for further queries regarding physician documentation, send us an email at beheldit@qrmd.com. And as promised, we will be sharing the presentation slides with you as well. And also, we are going to share with you a free ebook titled How to Master ICD-10 Documentation in 10 Days. This is going to be really helpful for all of you because that ebook was established after great research, and this is going to tell you how exactly you would be able to do the documentation in the next 10 days specific to your specialty. So again, I thank you a lot for joining us. Hope to see you in our next webinar as well. Have a very good day.